Michelle, thanks for that introduction. I appreciate it very much. Somebody say, wait a minute. We should probably get started here. Our time is dwindling, and I want you to have the opportunity to hear from this distinguished panel that we have today. As Michelle said, my name is Tony Schueth. I'm the CEO and Managing Partner of Point of Care Partners. And what we have planned for today is we'd like to kind of go along and let everyone sort of introduce themselves. So instead of having, Michelle introduce us all, we chose to do that ourselves. And what we'd like to do is have an introduction of who we are, what our role is within our respective company, who our employer is, and to talk then about how we're involved in health information exchange. So we're going to go and we're going to do that introduction, and then we're going to talk generally about how payers get involved or are involved in health information exchange today. But then we're going to pivot a little bit, and we're going to pivot to talking about the Da Vinci Project. So the Da Vinci Project is something that you may or may not have heard of. Seema Verma talked about it in general. She didn't mention it specifically yesterday, but she did talk in general about payers and their involvement in standards development. I've been at some sessions where Da Vinci's come up, but nobody's really defined what exactly Da Vinci is and who's involved. And so we're going to pivot to that. I'm going to do 5 slides on what Da Vinci is. And then we're going to sit down and we're going to have a panel discussion. This distinguished panel did not come here to hear me present. So you didn't come here to hear me either. So we want to make sure that we get a lot of interaction. We hear from each of the panelists. So that's the plan for today. So everybody good with the plan? All right. So let's get going. And why don't I start and then we'll kind of move it. We'll go across the way and then we'll go a little bit deeper. So my name again is Tony Schueth. I'm the CEO and Managing Partner of Point of Care Partners. We are a health IT management consulting company. What we do is provide market intelligence, business and product strategy, and program management to different stakeholders, including payers, health information exchanges, a variety of different stakeholders. We don't believe that you can really be effective in terms of having subject matter expertise in what we do if you don't kind of go deep in certain areas, and so we limit those areas that we're going to focus on. Electronic prescribing was one of the first areas that we got involved in. We're also involved in electronic prior authorization, health information exchange, and transactions that support value-based care. That's my transition into the Da Vinci Project. We are the program manager, program management organization for Da Vinci. I have had the honor of working with the folks on this panel, and I'd love to have them introduce themselves to you. And so I'm going to start with Tim. And if each of you could sort of tell the audience, your role and your role in HIE and person. It's a good place to start.
So I'm Tim Pletcher. I'm the Executive Director for the Michigan Health Information Network. I got involved in HIE back in 2007. So I was the founding director under the state designated entity program. So we're one of the ONC originated creatures, which is when I met Tony. We've been very adamant about driving use cases that create value from almost the very beginning, focused on engaging payers to support and fund and pay for, and really help drive the adoption of health information exchange. We're about 100 people now. We just recently announced the creation of a subsidiary nonprofit called the Interoperability Institute, which I won't talk about, but we've been super busy.
Hi, I'm Travis Simmer, and I'm Chief Medical Officer for Blue Cross Blue Shield of Michigan. I also represent Blue Cross on the MIHIN, Michigan Health Information Network Board, and chair the State Michigan Health Information Technology Commission. My main role is to align the payment model within the Blue Cross sort of pay-for-value system to ensure engagement and forward movement of both professional and facility providers in the state of Michigan in support of health information sharing.
Hard introduction photo. I'm Nita. I'm one of the medical directors Partners for Independence Blue Cross and Medical Affairs. My subject matter expertise is with cardiology and sleep medicine. I represent one of the co-leads for Da Vinci use cases, which is the Payer Coverage Decision Exchange. And glad to be here and learn from all of you.
Thank you. My name is Raj Davda. I am Medical Director with Cigna. My allergies just decided to act up this afternoon, so excuse me if I cough or let me apologize to start with. I support our quality program for Cigna at the national level, and I'm also responsible for provider connectivity and health informatics within Cigna to try to bring in clinical data. Cigna has been involved in value-based care for almost a decade now. We have over 250 ACOs across the nation and probably about 400 contracts for bundled care and episodes of care. So we're very interested in bringing in clinical data and information, not only just for health plan quality, but to drive our value-based programs and our care coordination programs.
Thank you. As you can see, we have quite a panel, and I'm super excited about the rest of it, the rest of this time. I think I'd like to start, Tim, with you. Every HIE that's in this room is doing something with payers, but they're all looking for, what more can we do, and what's the opportunity? And I know in Michigan, you're very active with your payers, and I wondered if you could sort of describe a little bit more about what Mine does today.
Sure. So we currently have all the payers under the tent, so to speak. All of them are paying something, not all paying full freight. But we have this thing we call the use case factory. So originally we tried to get everybody to join the network, and that didn't go over very well. Even with Blue Cross, we went and said, please join our network. And they said, yeah, we'll sit on the board and we'll contribute, but we're not going to give you any money. And I'm like, oh my goodness, what kind of job did I get into? And that discussion led to, hey, we're only going to pay for value. And then we said, okay, well that makes sense. What's value? And that kind of led to a very fuzzy conversation about what exactly does a health plan think value is. And that led us to, there were certain activities that would ultimately produce value of reducing utilization and leading to better outcomes, but that the health plan community had very little faith that, even though it sounded good on paper, that you could kind of go the distance and produce results at the end. And so we basically decided to chunk the conversation down from join the network to focus on a particular use case to advance. And we happen to pick net discharge and transfer, ADT notification is a good use case. And what we said is, it's fine if you don't want to use your, you don't want to pay us. But what we'd like is for you to use your market power, market presence, and ultimately take some of the incentives that you're giving to providers for population health management and value-based care and allocate a sliver of it to participation in these use cases. And they said, okay, we can probably do that. And I think the result was they were shocked at how quickly we went from 0 participation to 93, 95% in less than a year for that kind of activity. And we've been kind of repeating that model a lot. And so what we've been able to do is line people up to say, use what you can do as part of your existing infrastructure, tap the existing incentive programs, motivate something that creates the value chain moving. And then, at the end of that, once we got to critical mass of a particular data flow, you have to pay full freight for that actually being proven out. And that pattern has worked really well as we moved on to 10, 15 different use cases.
Dr. Simmer, you've been actively involved with MyIN and Health Information Exchange. I spoke to you, spoke as a sort of preparation for today. I know that you're an advocate. Not only in your words, but the fact that you're here, just proves how important this is to you. Help us understand your sort of philosophy toward health information exchange, and perhaps your company's philosophy as well.
Okay, the first thing is that we believe health information sharing has to originate from all points, and the destination needs to be all points. This is not, we have no interest in supporting issues where people will share information among their client base, among their EHR users, etc. It has to be all point to all point. And that means it has to respect the structure that has been established in the state of Michigan, which is a hub and spoke model. MIHIN is the hub, and all the hospitals work with their qualified organizations or local HIEs, health information sharing organizations, to move the information to the hub at MIHIN, where a number of things occur. The first thing is it's only shared if the legal umbrella exists allowing that to be shared. In that hub, they know who has an active care relationship in the provider community with all those patients, so that they can make sure that they are sharing information based on the right to treat as part of the HIPAA authorization. And then they send that information out to the local health information sharing organization, and it goes to where it's needed to go. You must respect that hub and spoke system if it is to qualify for Blue Cross Blue Shield money, because then we can build something that's scalable, and each subsequent use case can use the infrastructure, the legal infrastructure and the technical infrastructure without having to duplicate it, and everybody is sending information out once, not to a variety of organizations with a different client base. So our philosophy at Blue Cross has been that we will support information sharing activities that respect this, and it's allowed us to use that support to assure that we keep building a better and better system in the state, because frankly, until people are using it, they're not very careful about making sure that everything they contribute is essentially clear and understandable to the users. And so we've been able to support a sequence of information standards that everyone must abide by, and we sort of increase the expectations over time. So to me, it's all a matter of, you don't want to be building something that's local and sort of tentative. You really want to start off with a model that's scalable from the very beginning and continue to work hard at supporting it.
And Dr. Zimmer, aren't you unique in terms of what Tim talked about, how you're encouraging and incenting physicians to participate in HIE?
We have some things that are very unique. We have about $5 million that we'll be spending over a 12-month period to pay EHR vendors within the state, so that none of the doctors have to actually pay the vendor to move out to push out the information to MIHIN as we move to leverage the HL7 standards to push information out. We are working with the EHR companies to make sure that they're able to do that according to standard. And for a 2-year period, we're paying for all the physicians in the state to have their EHRs perform that function. And the reason for that is that you can't really organize all the users of each EHR to pay for the functionality and do it one at a time. You want to organize that effort. It saves a whole lot of money. It's a once and done concept. And then you have the infrastructure upon which to build, because everybody needs that clinical information. It needs to come out of the EHR, head to MIHIN, and then move on to all of the eligible recipients according to the information contained at the hub as to who has a right to know for payment purposes, for treatment purposes, etc.
Nita, you are involved with health information exchange, broadly. Can you tell us a little bit about that and some sort of lessons that you've learned through working with health information exchange?
So I think I have a dual perspective, one as a provider because I still practice, and one as a medical director, where you are trying to see from a very broader perspective of the population as to what actually is useful. So what an HIE provides is beyond what an EMR can, because an EMR is usually customized to what an institution requires. And that might be different for different institutions, whereas with an HIE and the clinical activity history that can be provided, it can be of tremendous help. And there are several new entrants into the healthcare landscape. We talk about just in the hospital, and then we have the post-acute discharge planning, and that includes a meal plan or transportation, and all of these are very important entrants in the future probably, but also into the value-based care system. And having the HIE is helpful to a provider as well as to the payer. To a provider in terms of establishing a better care plan at the time of discharge. So providing access to them is, I think, more crucial. It is available, but how easily is it accessible? And does the provider know about its existence? So those are some of the trends that I see, and I think if we can get to a common platform where a provider is more informed about the existence of these HIEs, I think we could just use the system more effectively.
Thank you. Raj, you were also involved in several different initiatives. Can you describe what you're doing in HIE today or with information exchange today and some lessons you learned?
Yeah, I think our initial foray is predominantly on our MA side of the business. We work with 3 or 4 state HIEs, and then on the commercial side, we've started working with like medical. It's not a technical HIE, but I think the issues are the same, really. As a national health plan, the biggest challenge is scale, right? And scale mainly because of a couple of reasons. One is the data standards are different. If you look at one state HIE or another state HIE, there's a lot of solving to do, and it takes a lot of effort on our part to try to solve all those data standards and formats and those sorts of things. The second really is the legal issue, right? I was talking to somebody this morning, and their HIE, I guess, has a rule that you have to get patient consent. And when you think about HIPAA and the health payers are part of the covered entity issues and all that, all those legal barriers are very hard. If you think about scaling Cigna, we have over 15 million members. You can imagine legal issues of trying to get all those consents done. So I think those are sort of the 2 largest challenges that we face. I think even the ADT data that comes back, it really is not of great data quality to be able to use right away. There's a fair amount of work that we have to do to make it usable. So I think those are the challenges that we face.
With the ADT challenges that you're talking about, do you find that to be universal, or is it better in some places than in others?
It's mixed, better in some places and not so good in others. I think somebody had mentioned in one of the earlier meetings today that they get ABT and all they get is demographics. There's nothing populated elsewhere. There's no diagnosis or anything like that. So our job at Cigna is really, if you think about it, is to make sure that providers get real-time notification when things occur, which typically does occur, but we also want to bring the patient into it. So we have technology that connects our patients. So if we can do that simultaneously, then both patient and provider get simultaneous notification, and we can serve that function. So I think a more uniform standard would be very helpful.
Tim, I think we're going to switch slightly to perhaps you could describe a little bit of what MyHIN is doing today in regard to their functionality and connectivity.
So we have a kind of flywheel. I'm trying to describe it, but we're about building infrastructure. Financial, legal, technical are all parts of that. But one of the key pieces is this little flywheel here that essentially we work with the payers, and we started with Blue Cross. We now have all payers participating in creating incentives or piling on to incentives. So the provider gets credit for participation in a use case from each of their payers. And we take our participation fee and we let them negotiate down their participation fee, not to zero, but down, so that if they take incentives and give incentives to the providers to send good, clean data and participate in certain use cases, they can reduce their participation fee. And we don't really care, or rather I'd say we want everybody to do a good job to get their financial incentives for participating in use cases. So we work with the payers to tee up, here are the use cases next year, here are the details around them that are going to qualify for incentives. The provider community starts to participate in those use cases. We run the conformance reports on those use cases, and then we share those conformance reports back to the state, because they're a big source of incentive as well, or back to the payers. And then the payers make the determination on whether or not they're going to give the incentives to the providers. It's sort of like school teachers, where we want everybody to get an A, and we don't make the decision on whether whatever the report card says, someone gets their allowance or not. So we're not trapped in the middle of the sort of whole money thing. So it's in our interest to have everybody send good, clean data. And what this does for us is it's sort of each time they put out an incentive, it turns on the spigot, so to speak, where we get lots of data flowing, and very quickly we get to critical mass of the data flowing. From day one, the model has been get to critical mass of the data flowing, clean the data up, and then get to critical mass of people consuming the information. And over time, each of these data flows starts to give you kind of a data lake that you start to do more interesting things in. But it completely hinges on our ability to get those spigots turned on at the beginning and doing those conformance reports. Because very often, HIE gets blamed for either not having all the information or they get blamed for poor data quality. It's not really the HIE's fault that we have poor data quality. And so by generating these reports, and here's an example. This is before and after. So when the incentive was, please send the data. So in this little Christmas tree diagram, each of those little squares is a hospital. This is a summary report. Red is less good than green. And what happens is the first incentive is send data, and you get credit in the first year. The next year, you've got to meet the conformance report conditions. And so you can see the change that happens in terms of the red going to green when the deadline comes up for actually being able to receive the incentive. This is a wonderful thing for us in the middle, because people are actually changing their work process to clean up that data. And it ends up having it come cleaner from the source. And without an incentive process tied to sending data, it's really hard for the IT organization in a provider setting to change the workflow, to stop what they're doing, and improve the quality of their information. So this little flywheel has been magnificently powerful for both driving adoption, but then getting usable information through the system. The way this sort of translates is just a natural evolution that sort of a happy coincidence because of this process we have set up, that we fold right into things like Payer and Da Vinci. I'm going to show how we work with provider organizations to do that. Dr. Simmer mentioned how they have worked with all their physician organizations to provide some incentives to get to the EHRs. They do this through their value partnerships program, and other payers do this. It's just that they don't have 70% of the commercial market, so it's not as impactful. But Mayan signed up to become a Da Vinci implementer just recently, and so about a year ago, maybe 9 months ago, under the value partnerships process, we worked with them, and in a lot of these use cases, there's some things that are required, and then there's some optional things that you can do if you're a bit of an innovator. And so you see here the section that comes out of that document for FIRE, and if you can't read it, it's the first thing it says, register vendor's FIRE server with MyHand. These are little things that make a big difference that they can get points for on their incentive program. The next one down is attest that the vendor conforms to the minimum Argonaut data query IG. I mean, you can get a flavor, it builds all the way up. So that there will be a group of physician organizations who are at the forefront, who've elected to go down the path to essentially set up their FIRE infrastructure and implement the first Da Vinci use cases. And they're tapping into their incentives that they normally get for quality improvement or population health management. And this is just a piece of the journey on the way. And it's built into our regular cycle and our regular process that happens on the hospital side. And then usually what happens is that on the commercial side, there are carrots to drive this process. And then maybe 18 months later, on the state side or the Medicaid side, they kind of come along and make it requirements or tie in more of a stick type approach. And this sort of moves us all along, and there's kind of a 2-year window to kind of get progress to happen, but it's constantly pulling with the carrots and constantly pushing with the sticks. And Dr. Schueth mentioned this active care relationship service. This is how we solve patient matching. It's how we solve a lot of the attribution kinds of things. But that's a use case that folks are incentivized to participate in. And even the payers are incentivized by the states, by the state to participate in this. And it's how we migrate everything to sort of a query-based infrastructure. And so in this process of working with all the actors in the ecosystem, they're telling us where their FIRE services are and how to get to them. One of the problems that we found with this Da Vinci stuff is that providers are not very excited by this self-service concept of a health plan coming right to their EHR and grabbing the information and taking it home. And so this will give us a couple of years to work through what we're calling FIRE stations, which is a way to take the population attributed to the physician organization and kind of broker. Is anybody here old enough to remember proxy servers? Yes. Remember, the way we made the web work in organizations, we put proxy servers in front of a bunch of things to give people comfort. So we're envisioning putting these FIRE stations that have got the population in front of some of these physician organizations who've got to deal with multiple EHRs to sort of help broker the relationship between the payers just coming in for self-service as opposed to it kind of coming in and being managed by the contracting entity in the middle. So this FIRE stuff can kind of be managed in a way that is not as scary as it could be if it's just the Wild West of everybody doing what they want.
Thanks, Tim. At this point, and I'm glad Tim brings up Da Vinci because I think this is the time that we pivot to a discussion about Da Vinci. What I'm going to do here is really quickly do some level setting. What is Da Vinci? But again, I assembled this distinguished panel. They don't want to sit here and listen to me talk, but I do think that we should do some level setting just before we get too far into this. So what Da Vinci is, it's a multi-stakeholder, really, in a way, a little payer-heavy effort to leverage the FIRE standard, the HL7 FIRE standard in support of value-based care. Because of this multi-stakeholder effort, we have an antitrust policy that needs to be sort of included in every presentation. We take that very seriously. I want to talk, though, about how Da Vinci started. it's kind of interesting where really what happened was, or the seed for Da Vinci really came from the Argonaut project. Some of you may be aware of that. That's an effort among payers and technology companies to leverage FHIR in support of other use cases. And what happened was payers that were involved in HL7, what they started to do is they started to see the success that Argonaut was having, and they said, we want some of that. Now what they specifically said is, listen, if we're going to be able to support value-based care, we have to be able to get the right information at the right time to providers that with the right coverage information, benefit information, and with the ability to coordinate care. And so this effort began to form. And you know, it's interesting. Success has many parents, they say, and failure is important. So Da Vinci is a success story. If you measure, at least at this point, in terms of number of entities that are part of Da Vinci, if you measure it in terms of, you know, it being included, you know, presented at CAMS, included in regulations, it's being, if you also measure it in terms of throughput, which I'm going to talk about in a second. But I want to talk about, and I want to bring up, because I think they deserve recognition, 3 people and 3 organizations that I think, and I've been sort of involved in this, or at least, you know, really close to this from the very beginning, that deserve credit for really pulling together Da Vinci. One is Sacred Moodley, who is the chair of the steering committee. He's a senior vice president at United Healthcare. So United Healthcare has been really instrumental in pulling Da Vinci together. Second is Linnell James, who is the executive at Blue Cross Blue Shield Association. He's been instrumental in terms of bringing all the different payers to the table. And the third gentleman I bring up, the third person I bring up is Bob Dieterle. He is a contractor to CMS, and CMS, fee for service, has been very active in bringing Da Vinci together. It's not to slight or, you know, any of the other organizations or entities that are part of Da Vinci, including Blue Cross Blue Shield of Michigan, IBC, and Cigna. They've all been very, very active, but those 3 organizations and entities really came up with the idea, worked, you know, nights, weekends, you know, put in the effort to really pull this thing together. Where we are now is that we have 16 different payers, 9 HIT vendors, a dozen provider organizations, and we're working on 14 use cases, and we have 4 EHRs that are all part of this. If I'm in your shoes, though, I'm also wondering who are the other ones? And are there payers that are in my market that are part of this? The answer is probably. I do have 3 slides that I put in the appendix. In the interest of time, I don't want to get into those, but you're welcome to look at that or go to the website to see all the different payer organizations, EHRs, et cetera, that are part of Da Vinci. Da Vinci's organized. It has a steering committee that sort of runs things. That steering committee, again, is chaired by Sacred Moodley from United Healthcare. It has other members of the organization that are worth calling out. 3 different payers, 2 providers, 2 IT vendors, CMS and HL7 are all part of that steering committee. A woman that works for me, Jocelyn Keegan, is the program manager of it. Viet Nguyen is the technical advisor. There is an operating committee, and then each of the different use cases have kind of a project lead. And those folks are consultants that that are contracted basically to HL7 through us. And we, the idea is to accelerate standards development, not to subvert it. You know, the ANSI accredited process for developing standards is being followed. It's just being accelerated because there's a concentrated effort to move things forward. Okay, I have 2 more slides. What Da Vinci is doing specifically is they're creating requirements for implementation guides for reference implementations and tools all around different use cases. And then payers such as Blue Cross Blue Shield of Michigan, Cigna, and IBC are working with providers to do demonstration projects to prove that this works. It's all being done, and it's all going to be available in open source, so available to everybody. And my last slide, and I'm not going to go into, I could probably spend a half hour on this, and I'm not going to go into detail on this, but is the use case slide. So my panelists can't see this, but I know they're very familiar with the use cases. I'm going to orient you to this slide a second, so that you know how to read it. Okay, first of all, there are 4 different focus areas for Da Vinci. The 4 areas are quality improvement, coverage and burden reduction, member access, and clinical data exchange. Okay, there are use cases that fall under those 4 buckets. And then the color coding works like this. The brown, or the rust, if you will, is balloted. So they've gone through the whole process. They've created an implementation guide, and that has been balloted. So that's where we are. A lot of times people say, okay, well, this sounds really great, but where is it in the process? That's where it is. You can see all these different use cases that have been balloted already. The lighter gray are things that are planned for the September ballot. The darker gray are use cases that are planned, that are in discovery and planned for the January ballot, which, by the way, is in Sydney, Australia, so if anybody wants to go, I'm going. I was not going to not go to Sydney. And then the last is the use cases that are in discovery that will be balloted after January of 2020. So you can see that we're making a substantial amount of progress. Now again, I don't want to get into depth on the use cases, I probably could. I think what I'd really like to do is ask our panelists to help us understand the use cases a little better. And Nita, I know you've been very involved in use cases. You started out by talking about that in your introduction. Can you tell us about the use cases you're involved in and kind of some lessons learned from that?
So I initially started out with some oversight with the prior authorization exchange and just working through the clinical workflow within a payer model. And while in it, I was asked to co-lead on the use cases for payer clinical data exchange. And 2 important things mentioned by Tony was reducing the provider burden and easy member access. So Da Vinci is there to deliver like any of the others, but I think the focus is mainly to reduce provider burden. A lot of I think one of the major hiccups that physicians face today is introducing a new technology is more work, and I think that is the approach which needs to be changed. And having that into the clinical workflow of the physician is basically going to help the payer because it helps transfer of information between the 2 providers, and this information is basically which payers across the board, not just one payer but multiple payers can use. And if there is a standard which is set, it is just easier transfer of information. So the use case that we're currently working on, like the clinical data exchange, it is designed very differently from the prior authorization use case. But the clinical information that was once used for prior authorization has the potential to be transferred to another payer. And we are currently working on an implementation guide to make that happen. And what is challenging is that every payer has their own proprietary information policies, and at the same time, there are certain standards which is used across the board. So the Da Vinci use cases are working on those common standards, and that is the reason I think the ability to implement that use case is going to be far more scalable.
Thank you. Raj, maybe you can talk a little bit about Cigna's philosophy toward Da Vinci.
Yeah, so we've been involved with Da Vinci, and I had the business lead, and I sat on the operating committee. So we feel that Da Vinci is kind of what happened to claims 20 plus years ago. Just as I started practice, because I never saw the time before that, of how difficult it was for providers to submit claims. And Da Vinci is the first time payers have come to the table with providers and technology companies to try to solve this problem. And the FHIR standard, really payers don't care what standard it is as long as it's one standard. And we've all set out, we've all agreed to FHIR as the data standard. Really, if you think about Da Vinci, its criticality is so important. If we are going to continue down this value-based journey, which I think most of us want to continue given the alternatives, we have to figure this out. And this is not something that can't be figured out. The technology already exists, so it's not something that needs to be developed. It's all of us sort of adopting it. Our interest has been in two use cases. One is prior authorization, and we did in the Schueth, we did the little interoperability showcase that Da Vinci did for coverage discovery. And I will tell you, when we took the video of it, or Da Vinci took the video and we shared it with our senior leaders, it was like an eye-opener that we could actually do this, and it was technologically possible. They didn't know that it was technologically possible. And so I think, providers, if you think about it, for physicians, just knowing when to ask for a prior authorization in and of itself is a burden, regardless of actually submitting it. So if we can reduce some of those things, it'll be very useful. For payers, it's very expensive. For prior authorization, from physicians, we get more calls about, do I need a prior authorization? And then, if you're a physician, you'll know that we do mess it up sometimes. We do tell them that they don't need a prior authorization, and then we deny it in places of the lack of prior authorization. So we need really technology to solve that, because the human interaction is difficult to solve. And the other one we're obviously interested in is gaps in care and HIEs, and getting that information to improve quality.
Tim, you said you're an implementation partner for Da Vinci. Can you talk about, how does Da Vinci fit into health information exchange? Is it how's your vision or view of Da Vinci with HIE?
So this idea of payers doing self-service to EHRs is concerning on a number of levels. I've seen situations where payers literally have login IDs into an EHR to go and find and pull data out that they need to close the gaps in care. And so I think we need a better mousetrap. And there's the technical pieces, and I think Da Vinci solves some of that. But I think the trust factor, the consent part, the way we use this active care relationship service is to sort of say, here are the keys, who's allowed in to do what. I think that is the sweet spot for HIEs to sort of help broker and facilitate that process. Because again, I don't think the payer really cares so much about the standard as much as having a really predictable, consistent process to solve the problem. And I think the HIEs can broker that well. And I think in the past we've had, in us versus them, kind of mindsets out there. Healthcare is very contentious, and I think we've got to figure out how the HIEs can cushion some of that. I think if we don't play a big role in that space, then we're going to be disintermediated. I think we need to step up and make sure that doesn't happen.
Yeah, I would agree with you. I think the technology part will be solved, right? I think we're on the cusp of solving it. I think what takes 18 months to 2 years is the legal consent issues, right? And HIEs or some trusted partner can solve that. Because we just don't have the capability to go out to 600,000 providers and 15 million members. It's never going to happen, right? So if somebody can help us solve that consent part, I think we would have, whoever that is, whether it's HIEs, would really add a tremendous amount of value.
Dr. Singer, Blue Cross Blue Shield of Michigan is a premier member of Da Vinci. Can you talk about the philosophy? Was it hard to persuade your organization to do this? Were they on board immediately? What's sort of Blue Cross Blue Shield of Michigan's view of Da Vinci?
Even asking normal things in our organization is usually hard, but this wasn't really very hard. We have a lot of business that hinges on our getting clinical information. We have a big Medicare Advantage program that needs to get all the diagnoses in, or it has a high impact on the organization. It also needs to get the STARS quality information, and these things are on scale. Many hundreds of, I think we have 600,000 or 800,000 Medicare Advantage members. We have just a large amount of information that's needed. And think about the need to manage information from the standpoint of delivering consistent care. The ACOG, the American College of Obstetrics and Gynecology, has about 150 recommendations for things that one should do while caring for a pregnant patient. If you asked every physician to review the medical records for 4 of those measures, you'd bring them to their knees in terms of burden. So what we've had to accept inconsistent care simply because we don't have the infrastructure to make it consistent. With Da Vinci, what we're basically saying is that the EHRs will push the information out to organizations that have the wherewithal to sort through the vast amounts that are there, pull out what's needed, and reassemble it so that the quality measures can make themselves. And I know that we're far away from that, but fundamentally, when you look at all of the many, many recommendations, and when you talk to providers, they usually say, pick the 4 measures that you want. Well, unfortunately, if you're a patient who's pregnant, you don't want just 4 measures, but 150 delivered consistently. So we've really got to view this as not just deburdening providers, which of course is very important and it's very near term, but also preparing for a reality where we can go beyond our current limitations to deliver consistent services where you have the information managed according to a model like this. And it's just going to allow us to deliver healthcare so much more effectively and consistently. We've needed this for a long time, but it finally has gotten to the point where the technology, the standards, and the momentum is behind it. And I think all of us are eager to bring that future about as quickly as we can.
It is an exciting time. At this point, I can ask another question, but I'd like to sort of invite the audience, if you have any questions, to step to the microphone. There is someone that's stepping forward, so instead of asking the next question, I'm going to let you, is that David?
It is.
Okay, David, please.
Yeah, I really appreciate all the great work on transport with Da Vinci. I'm wondering, you mentioned consent. Are there other things you're having to do to get the practices, the ambulatory practices, to become willing to send data? I mean, if they're unwilling, and when we see this at places, having the great standards isn't enough. Are you doing it through your provider contracting?
In Michigan, we've crossed that such a long time ago that we don't face any questions as to whether or not the data will be there. The problem is that the meaningfully useful certified EHRs are not equipped to be delivering the information even according to the current standards in a manner that suits this purpose. And the EHRs have to become functionally prepared. They may be technically prepared in some way, I can't speak to that, but they're not functionally prepared to send this information out, the CCDAs out on a daily basis. The providers don't have the resistance. We have a little bit of resistance in the behavioral health area, but fundamentally we're talking legislature. It's the EHRs that we have to engage to be able to not only deliver it so it's consumable and according to a standard. And that's why we're working with the EHR vendors in Michigan. And we're essentially signing up all the doctors in the state who use each EMR, creating a contract with the EMR vendor and saying, you've got to send this out through the MIHIN mechanism that's described. We don't have resistance on the provider side. We do have some EHR vendors that say that they have so many things that they're busy with right now that they're not ready to get on board with this, so that we're sort of taking them as they are ready and putting them into the mix. But I don't see any other way. We're not going to have everybody on one EHR. But we're fortunate that MIHIN does have the legal umbrella that everybody has signed. All the business use agreements are in place. We're all covered in that scheme. So that was the very hardest thing we did in the first year, is make sure that we got those things signed. It was unbelievable resistance. But since that time, I would say the resistance has been non-noticeable. It's the IT departments that have capacity issues and the EHR vendors that have capacity issues that are the points of resistance, not providers who will share data in the med surg area.
It's all resource constrained. The sort of battle that is historically there, we kind of got through an awful lot of that early on.